Good evening, all the aspirants. Today is a special session, and the speaker for today we have here is Dr. Ranajit Chatterjee. He is a HOD in critical care at Swami Dayanand Hospital, Delhi. Sir, you can start the session.
Well, good evening again, my dear friends. I think we have met before also on webinar, not maybe directly live, because everything nowadays on webinar, your exam is also not live, unlike our times when we had to give the exam. We went to, for my EDIC part one, I went to Malaysia, and from EDIC part two, I went to England, where we got a live patient, and the exam pattern was completely different than what you are giving now. So now there, the exams till 2013 was by the patient sides, and from 2013 a different type of format came, and nowadays it is more a robotical type of exam. Beforehand, when you are giving the exam, it has a lot of questions can be asked by the examiners according to their own will, which is now being restricted. You have a set pattern of questions, you have a set pattern of pictures which you have to answer. Remember, all of you might be doing intensive care for the last couple of years, and you are all consultants. You don't have to prove yourself by passing this exam, you are already consultants. And I'm sure that as you don't have to prove it, you will automatically pass it. Because those who are working in the intensive care, they will pass this exam. Because it is the first part of the EDIC is basically to test your theoretical knowledge. The second part of the EDIC is basically to test your practical knowledge. So they will see how practically you are oriented as a consultant. And so I am sure that most of you will pass this exam. So I will share my slides. As you know that the exam has been divided in approximately 2 hours. And you have a clinical case scenarios. You have also that is the pictures and different type of graphs. The three parts will be coming there, the CBS part and the CCS part. So computer-based scenarios will be coming and the clinical case scenarios will be coming. And you have to answer them in the stipulated time as quickly as possible. And read the question very well. Have you attended my last class where I have already shown you about certain cases? Certain atypical case. Did you see? Have anybody attended? You can just unmute yourself and talk if you can. So that because monologue is always very boring, you know. It would have been a dialogue, it is always better. Just see the type of scenarios that you'll be getting. We have already discussed many. Now you must be reading also, but be free in your mind. Only 3 days left for your exam. Do not take any stress here. I have seen very familiar names which are here. We have interacted before. And there's a question on reverse triggering that was coming, that why it is different. We'll discuss this today. All right, because this type of things will be asked. And I'm sure that you must have read about double triggering, reverse triggering, pseudo reverse triggering. How many of you know about that? So you can Google it again. You will get. So there is not a problem. Now Google is always there for your help. So So suppose you get, this is a very common question that you get, and we have already shown it, I think, before, but I thought to change certain pictures and show you again the newer ones. So what is the lesion? What is the reason of this lesion? What do you think that what is this one? So when you get this type of picture and that to the pons, you just can't think anything else but any infarction in the pons. Somebody will think an infarction in the pons. But exactly. So nobody is going to give you any infarction in the pons suddenly in an intensive care. So obviously it will be related to something which is basically related to our own subject. So that you have to keep it in your mind. And central pontine myelinosis, they can directly give this type of picture also in the occipital lobes. And they can ask that completely changes the picture actually. So if they keep the same picture and you get two bilateral occipital lobes, this type of opacities, white opacities in the MRI, what do you think what it will be?
West
Any
syndrome.
Press.
pregnant?
Press
Press.
syndrome.
Press.
Yes, right.
Press,
So
press.
again, when you say the full terminology, all right. If you say press, it's fine, but uh, it is better that you always do not give the abbreviation, but better you say the whole terminology. So that will be better. Yes, that you are all prepared. I'm sure. So you might have seen this one. This is I am very fond of this one. What is this one?
Helmet and IV.
All right. This is an helmet and IV. Do you use it?
Pediatric patients.
Pediatric patient. This is an adult patient here. It's in my ICU. Whatever I'm showing, I am not showing from my ICU. See the settings that we are giving here in the helmet and IV. We are giving a setting of around, we're giving a high flow here, around 55 liters per minute. We are giving what is the end of a face mask is the beginning of an helmet. So I'm giving a PEEP, which is the end with the that is the expiratory positive airway pressure EPAP of 10. And the IPAP here is 10 plus 15, that is pressure support is 25. I'm giving a 50% oxygen. Helmet should always be used with the help of a ventilator, not with the help of a BiPAP machine. The main things that you should remember during a helmet, if by chance they give it, because these are the new things that will be coming up, and they might be giving you either a video or maybe a picture, and what settings they've asking you. So remember that in order to get the best of the settings, I start with a PEEP of 10 and a pressure support of 15, and we give we try to decrease the circuit length to around 65 centimeters because these are all studies. These are all studies related to helmet. So 65 centimeters because it has a very big dead space. So you have a chance of asynchrony, a lot of asynchrony is there. So you have to give a lot of flow inside, as much as flow is possible. I have to keep the rise time as less as possible. And there's a cushion, if you can see properly, there's a cushion also. I think there is an external cushion, you can see this, the translucent one here, but there is an internal one also inside. So you have to fill up, you have to basically inflate that cushion also. This circle is basically this one, the circular thing. You can open this up, give the patient some amount of water, and the patient can talk. These are the patient can speak, the patient can read, the patient can eat. These are the advantages of the helmet. The main problem is that the CO2 washout is not very good, and obviously you have to use a lot of flow here and use a helmet, use a ventilator, that to a turbine-based ventilator, which generates a lot of flow rather than a compressor-based ventilator. These are some small tips about helmet. If I get a chance anytime, I can discuss it in details. So
IEU issue is the same.
yes, yes.
IEU issue is the same.
How I use
IEU issue.
IE
I
ratio. All right, IE ratio. Yes, IE ratio. See, IE ratio you keep it is around 1:2. All right. And normally when this patient is breathing spontaneously, when the patient is see when I select an IE ratio in a BiPAP machine, I select a spontaneous time mode. The IE
Yes.
ratio is basically meant for the time part if the patient is suddenly stopping its ventilation. Then the patient then it will be a backup mode that has been given. Here in a pressure support mode, if you go to the advanced settings, you will find if the patient stops breathing, then there is a apnea ventilation is on. There only the IE ratio comes into action. So normally when you are ventilating from a ventilator, that it becomes different from that what we are ventilating from a BiPAP machine. Yes, I keep the IE ratio. But if I have COPD patient comes, I keep the IE ratio 1:3 or 1:4. If an ARDS patient, early ARDS, I'll keep the IE ratio at 1:1, 1:1.5. It varies accordingly of the patient conditions. So this is one. So you know what is this one? This is a very easy one. I showed a different color last time. I'm showing you a different color this time.
This is
So why
methylene.
yes? This is the
This
color
is
of the urine. What is the
e-urine.
cause?
Green urine, sir.
Green
Yes.
Yes,
phenol.
Is
what is
someone
the
when
Propofol
Propofol.
infused.
they
Propofol.
give
Propofol
flu,
infusion leading to
right? Fantastic. It is a propofol infusion. You all know about it. This is a phenolic derivative of the propofol. Propofol gets metabolized by oxidation reduction and glucuronidation by the cytochrome 450 in the liver, and from there some of the phenolic derivatives come out that basically sometimes cause this problem. It is completely harmless situation, but they might be giving you. Last time I showed you uh, urinary color, so I'll show you that also, because who knows, they might be giving this one. If you see this one, what is this one known as?
cola colored urine.
Yes, this is for
hydroxycobalamin, I think, was
Paraquat.
given.
this is
No.
what
This, I think, patient was given hydroxycobalamin.
Hydroxycobalamin.
right, because hydroxycobalamin is used in a cyanide poisoning,
Cyanide
so that is
toxicity.
cyanide toxicity, and from there it is an antidote itself, because one about this color. All right, so what is this?
Just one query.
Sinusoid
Blood
sign.
sign.
What sign?
And the
Blood
last,
sign
Prolix.
and sinusoid sign.
so
First
this
one.
basically is
Sinusoid
showing a
sign.
very small pleural effusions, isn't it? You have to remember that the left one is the quad shine, basically is a static parameter, whereas this is the M mode, there's a dynamic parameter of uh, what is shown in the with the help of ultrasound. Fine, fantastic. What is the diagnosis of this one?
SVC.
This could be Harlequin
This is the
syndrome.
intestinal syndrome. SVC obstruction syndrome.
Yes, easy
Could
time. So these are easier questions than the last time I gave. So these are easier questions, and you will give easier ones. So don't worry. If you have not attended the last class, can you tell what is this one?
Abdominal pressure monitor.
Yes, but they will not give this advice, this hint of monitoring device following exploratory laparoscopy. They will not give you. So they will directly this give you an abdominal pressure monitoring device. And most of you have not seen this one. Again, I'll show you, because I feel very deeply that they will give you this question.
Anaconda. This is Sedaconda.
Idaconda.
Anaconda.
That is already written, isn't it?
Yes.
So, and you saw, I think, the last time, many of you, and those who have not seen, this is anaconda device, anesthesia conserving devices, which are being, we use basically isoflurane and sevoflurane to this one. It goes to the patient around 2 ml per hour, we push it, and it goes to the patient again. The patient breathes out, which is being absorbed by one of the absorbers here in this black color device, which again push it back. It is just like a HME that is being used, advanced type of HME. That's what is being used here. So, uh, so they will give you definitely some videos. I have shown this video before also, and you can tell me what is this video. It's very easy. I showed you last time.
There is absence of pleural movement.
There is absence of pleural
Cleaning.
movement, that is lung sliding, abscess lung sliding,
That's right.
absent lung pulse. See, the pulse is also not there. Otherwise, you would have a pulsatile sensation here.
Barcode
Absent lung
sign.
pulse.
Barcode.
In the aim
A
board,
line.
I find a barcode sign.
Lung.
Barcode side.
And
Pneumothorax.
yeah. And here is what is this point known as?
Lung.
Here is a seashore
Lung
sign,
point.
lung
Lung
point. So
point.
everything has been shown here. They will definitely give this type of questions to you. So be ready for any, because ultrasound is being used in such a way nowadays. Every intensivist is becoming an ultrasonologist. So they feel that we are an ultrasonologist. We are not. We have to only use this according to our own situations. For example, this one. A ventilated patient following a lower abdominal. Again, they will not give you this type of hints, but still I'm giving. Abdominal surgery suddenly desaturates and become hemodynamically compromised. I have given this question just to make you understand, again, to make you again remember how it presents. The P peak and the P plateau in the ventilator is normal. The D dimer is increased. What is the phenomenon in the echo called? How do you diagnose the
Pulmonary
condition
invade.
by the bedside?
McConnell sign.
So even without seeing, you are saying that is a McConnell sign. So see that how well prepared you are. So you will get McConnell sign. I don't know why they are very fond of this question. So they'll give this type of questions. So now, if I can show you some graphs, some loops and graphs. For example, this one. What is identify the
Double
situation?
trigger.
Can I ask you
Oh,
one question before
yes, please.
regarding this greenish urine? I mean, should we mention that it might happen with methylene blue infusion as well? Because there should be some differential diagnosis, isn't it? Or
They basically will ask you if they. I believe that they'll ask. Don't ask you for the differential diagnosis. Okay, and some
right.
phone is.
Okay.
I don't believe that they will give you some differential diagnosis, but still, I think directly for the for your for the. I better to say that this normally used seen when the propofol is being used for prolonged time. So, for example, not directly it comes. I have not seen. Have anybody of you seen?
Yes.
You have seen?
Yes.
And what do you find? Well, it
I
is
when
for
I,
propofol for prolonged infusion.
no, with methylene blue.
Your methylene blue. It comes with methylene blue also, but that is not exactly this type of light green that comes actually. Certain dyes like methylene blue, definitely it causes. In certain UTI infections like pseudomonas also, yes, we might get green urine. But propofol infusion, I think, is the right answer to be given. But yes, if they ask you a differential diagnosis, even sometimes bile when gets secreted, I don't know whether it might be. But pseudomonas, yes, I remember that might be there. So, yes, you are right, my dear. So, you might get this type of
Sir,
confusion
can
might
paraquat
arise.
poisoning also?
I'm not sure. I'm not sure about paraquat poisoning. I don't think so. I'm not sure. I have to
Paraquat
check.
causes greenish discoloration of upper respiratory tract. I mean, lips, tongue, abdominal.
But urine, I'm not sure.
Yes. Urine, I'm not sure as well.
So, I'm not sure. I've not seen actually. What I've not seen, why should I tell you? But I was just telling you the reason of giving this question is that they might ask you this type of certain visual questions. They sometimes give you such very questions which doesn't make any sense actually. This type of questions also comes. So this is double triggering. You're right. So and how do you reverse this situation?
Increase the inspiratory
By
time.
prolonging the inspiratory time.
Increase the
Yes,
sedation
you are
as
right.
well.
By
And
prolonging the inspiratory.
Increasing sedation.
Yes, yes. By prolonging the inspiratory time, that is the answer actually. So if I show it this one, so this the question comes here. Basically, the inspiratory time is less. First of all, the patient triggers the ventilator and the breaths come. But patient wants to be there in that mode. So, but the inspiratory time is less, so it triggers the ventilator. Give me something more. So that is double triggering. But when a patient is deeply sedated, the ventilator basically triggers the patient that you take a breath. So basically this is a completely different thing. So that is reverse triggering. So I don't know that how much reverse triggering, because again I told you that reverse triggering has not been seen by many of us, because those who are not doing the night duties where, because it is seen mainly during the night time when the patient is deeply sedated. So that what is the second one is the patient's own breath, and obviously the tidal volume is increased. There is a chance of uh, uh, self-inflicted lung injury with this type of situations. That might be one of the reasons of why we tell that the reverse triggering might not be so good for the patient. Not very well seen, may not be, they might not be giving you, but in 2012 onwards, this has been coming off and on in patients. So this is reverse one. So I showed you this one about capnograph. They can give you anything. So read the capnographs well. They can give you anything there. So this is an endobronchial intubation that you can know. What is
Right.
this
Yeah.
one? What is this one?
Bronchospasm, the phase 3 slope is increased.
I think Priyanka, you are speaking, no?
Yes.
Yes, it is basically a bronchospasm. You can say basically this is a pigtail capnograph, known as pigtail capnograph. Seen in pregnant patients, in obese patients, the last part where the spasm is taking part, because they may ask you that identify the phenomenon in capnograph. So the pigtail capnograph. All right. So pigtailing. Yes, this is the last part of the spasm that comes, yes, that causes this one. So this is pigtail one. So these are very easy ones that you can very well, this they will not give. This they will not give. I've just kept it. What is this?
Ineffective
Ineffective
trigger.
triggering.
Huh?
Ineffective trigger.
Ineffective triggering.
Ineffective breath, right? Is ineffective wasted breath. So what basically what is the problem? Why it is happening?
The triggering is very high. You need to decrease the triggering, for
Yeah,
example.
they have to keep the triggering so high. So these type of questions they'll not give. This is a very easy question. So I showed you this one. Everybody answered this one. This is a very easy one again. What type of mode is this one? Again, they will not give this type of easy questions.
APRV.
But, yes, right. But they can give you this one.
Capture beat.
What are these two waves known as?
Capture beat and fusion
Shot
beat.
at the target.
So this is diagnostic of what?
Ventricular tachycardia.
Right. So the
Ventricular
capture beats, fusion beats, diagnostic of ventricular tachycardia. And what is this one? Young patient had cardiac arrest following this. What is this wave known as? What is the situation known as?
Epsilon wave. D Winter sign.
This is
There are two. Brugada syndrome.
Brugada syndrome.
Brugada.
that is the reason why I've given it. This is not Brugada syndrome.
So epsilon wave.
Yeah. Found in?
ARVC. Found in arrhythmogenic right ventricular dysplasia.
Fantastic. This is the answer. And I'm predicting this one. Why I feel my gut feeling is that they might be giving you this question. Very common in the European nations, this Brugada and this right ventricular arrhythmogenicity is not found much in our part of the world. But there, it is very common. They're quite common actually. So they might be giving you this one, this type of questions. This is right ventricular. Very good answer. Very good. Fantastic. So what is this one? Again, very easy one. Again, they will not give this type of hint that is there.
Osborne wave.
Hypothermia.
So very easy things. So this one, last time I showed you.
HOCM hypertrophy.
What is this?
Brugada syndrome.
Cove elevation.
Yes, again, this is Brugada syndrome. All right, cove elevation. So just have the difference between these two. Just see this one, epsilon waves they are giving. Here there is FT upstroke with the inverse T. But here you will give this coving is there. Big coving, you will not find this epsilon here anywhere. So they read these two parts well because any one you might be getting. So this is one of my another favorite questions that I always ask. I'll ask this.
Stress cardiomyopathy.
Pericardial effusion?
No, this is stress
cardiomyopathy.
See, they have given such a beautiful hint. Elderly, so they will give, if they give you the hint, elderly woman presented with breathlessness following her son's death. So stress, huge stress. Typical ballooning. But what is the image B represent? Question is that. Because they might be giving you, because if you are answering to stress cardiomyopathy is fine. The moment you say Takotsubo, what is the meaning of Takotsubo? You are a consultant now. You should be knowing everything from history to geography to science.
Trap for
what trap?
Trap for self
Yeah, right. Octopus trap. Octopus trap. Last time we discussed it. All right, many of you told it. That is fine. Octopus trap. They are definitely going to give you this type of questions that I have shown you last time. Again, I am showing you. I'm not going to do the details of this one. Just calculate it as quickly as possible. Is a triple disorder. So they'll be giving you a triple disorder. Metabolic acidosis, metabolic alkalosis, and respiratory part. Three part will be there. They'll be giving you a triple disorder. They may be adding a albumin to it also to complicate the matter. So you have to correct it for the albumin. You all know about it because you are doing it regularly. So do not forget that they're definitely going to give it. And I have not kept an image of a CT scan of giving it. They'll give you a subarachnoid hemorrhage or a subdural hemorrhage. Small bar hole will be there, which will be very confusing. So they'll be giving you the subdural hemorrhage, but they have to tell it that it is post-operative subdural hemorrhage. Remember this. Always look at the midline. There'll be a midline shift. Never miss it if you get a MRI or a CT scan of the brain there. So they'll be giving you that. And yes, they'll be asking you about the autopeeps or the waterfall phenomenon. So you must be ready with the waterfall phenomenon. Because again, I have seen many of my European friends, they're very fond of it. They ask about this waterfall phenomenon. And you must be knowing about this one. Pulmonary embolism, anytime they will be asking pulmonary embolism, be ready about this. But obviously, the newer inventions in critical care might be asked. So you should be ready for that. Now, last time I gave you, this is also very easy one, so I'm not showing it. Can you tell what is this one?
Ring stage malaria.
No, because
Malaria,
sometimes, yes, right. What is this? What is this known as? Because as most of the intensive care is related to medicine, sometimes they can give very intrinsic medicine. Sometimes, suddenly it might come. So I told you, say go and read the video, see the videos and the pictures in New England Journal as much as possible. So multi-cross appearances, you're right, human baby sources. So they might be giving you suddenly, it's not malaria, you know. You'll be confusing with this. So that might be the reason why, because many of the laboratories, they're also having their own microscope. They're doing the slides there. Many of them are doing it. And they might be asking you a question.
So what is this? Listeria?
This is multi-cross appearance inside the RBC. This is the human babesiosis. Babesiosis. So, you can see there are multiple questions like this. We can go on discussing. The main part is that read the question well. There will be a hint in that question. And that hint has to be answered. And answer it very specifically. Do not go this side, that side. You are all answering very well. I am sure that it will not be a problem for you to basically crack this exam. This exam is not very difficult, I tell you. Go with a free mind. Go with a free mind. When I went there for the part 2 part, I was thinking why I have come here to give this exam. I was feeling very bad about it. That I'll not be able to answer any question. What will happen? But when I went on to the exam, once and for all the chapters went on opening, my mind became very clear. And think what you are doing every day in your own day-to-day activity. I'm sure that you are going to clear it. I have no doubt, because the way I'm interacting with you, I have seen most of you are answering very well. Very well. Even if, and it is, it is very easy to be an examiner and very difficult to be an examiner. So it is very easy to ask questions. So now see if you get this type of question, this is the CCS. Last time I showed you a different type, now I'm showing you a different one.
Peripartum cardiomyopathy.
They will not give you this type of highlighted things which I have shown you. I have just shown you because, yes, right. So now, once you have diagnosed this case, there is no problem. Because the first diagnosis is very important. If you can't diagnose, then becomes a big problem. Like this one, which I gave last time. Again, I will be showing you. And I again have a gut feeling they might be giving you this type of questions. Those who have attended last time, they know the answer.
That was Takotsubo, I think.
Again, did you attend it last time?
Yes.
This was Minoka.
Again, you are telling Takoshubo?
Sir, it
I
cannot be
could
because
say Minoka,
angiography
I
is
think.
not involved.
45%, less
Yeah,
than
yeah, yeah.
50%
It was a
blockage.
Minoka.
Right.
We couldn't get.
So do not forget that Takoshubo is one of the reasons of Minoka, you know. So, but here you don't know whether it's a Minoka or it's a plaque rupture or it is what exactly it is. So do not comment on Takoshubo. This is Minoka. Many of you who have not attended last time, do you know what is Minoka?
No, sir.
No,
Sir, but
sir.
here is block, 45%.
That means
So
there
this
is no.
see, it is showing as if the patient is having a acute coronary syndrome, isn't it? It looks like
Yes.
this. But the angiography reveals 45% block. So it cannot be acute coronary due to blockage. So what is this? Myocardial infarction with non-obstructive coronary arteries. So what may be? It may be plaque rupture. These are the reasons. And the diagnostic rock is this angiography with less than 50%. And many a times during in our ICU, it is in sepsis patients, we get this one. Many a times you will see that ST elevation is coming. So do you think all the time the patient is going to ACS? It is not like that. Maybe it may be due to sepsis itself it is happening. Maybe due to pulmonary embolism there is something happening. We don't know actually what is happening. Maybe a pneumonia that is causing this, a stroke suddenly has happened. So the overall thing is known as Minoka. They will be giving you Minoka. So then they will ask you the question. Then they will ask you the question, what is the broad diagnosis? See, what is the question is the broad diagnosis. What are the salient diagnostic points? Then you will say that in the background of a 45% block, it is less than 50%. With a rise of troponin I and BNP, the ST elevation, it might be Minoka because the coronary arteries are not blocked, and reasons are this one. And then they are giving the questions, what are the causes leading to this condition? The causes leading to this condition is all these causes which are leading to this condition. It may be there it comes in the cardiac tachycardiomyopathy. Myocarditis may also be there. Atrial fibrillations might be there. So many things might be coming there. These arrhythmias actually. And here what may be the cause? Then what you are answering? Yes, I think here it is a case of tachycardiomyopathy. You know, how do you confirm your diagnosis? The diagnosis is confirmed by doing an echocardiography, by doing angiography. How do you differentiate from myocardial infarction with coronary artery disease? So naturally, there the blockage will be more. Treatment in this situation, its treatment is a traditional treatment. We sometimes have been found that the AC inhibitors and this dual platelet therapy initial stages has been working well, but ultimately we go for a single one after some times. And what is the prognosis is equivalent. It is not bad. It is not very good. It is equivalent to that of uh, the other coronary conditions. So this type of questions, when you are getting, you should be thinking about it, that what exactly they are going to ask. Different type, actually. Now this one is an easy one. Though it looks like to be an easy one. Do not think I am always trying to confuse you, There's nothing confusion in it. No confusion in it. So they are giving this one. So it looks like a case of
Guillain-Barré syndrome.
So it's the case of Guillain-Barré syndrome. But what I want to stress is that you have so many varieties of Guillain-Barré syndrome. So at all probabilities, they might not be giving you this one, but they must be giving you a Miller-Fisher variety or maybe another one variety. So they must be confusing you with this type of different presentation of Guillain-Barré. So because Guillain-Barré is such a common presentation all over the world that it might be asked, because they can go in different directions from this question. The main things that they can be asking you on this question is that whenever you get this type of scenarios, first of all, try to think, what are the questions that they can ask me? It should be coming in your mind. What do you think? I'm not showing you any question. What are the questions they can ask? Number one, they'll ask you about the treatment, that is about the diagnosis. So you've told the diagnosis. They'll ask you about the treatment. Then definitely they'll ask you how do you pinpoint your investigation, which investigations will pinpoint your diagnosis. So that means if you are not treating Gulenberry, you will not can't answer them. If you are treating Gulenberry, you can answer them. So what are the investigations that you are going to do?
Nerve conduction studies,
Yes.
CSF examination,
Right.
MRI to confirm the diagnosis.
What you will get in MRI?
Sir, just in case, like in case of Bickerstaff encephalitis, where there's confusing diagnosis, we can get MRI done also.
So in order to either to rule out my differential diagnosis and
Yes.
to see certain Bickerstaff variety and others, I have to go for an MRI. Yes, we got a Bickerstaff variety case just a few days before. You are very good, but you have to also tell them, shouldn't you go for a stool test? Because if those who are from India, they must be knowing that we had a very big outbreak in the city of Pune just 2-3 months back due to contaminated water. So they must be asking about etiopathogenesis. So Campylobacter jejuni is a very big factor, apart from the vaccinations and the viral infections. So they might be asking you this. So that stool examination, do not forget, is one of the easiest one that can be done. The serology that we have to say, the stool cultures, the serologies. So do not forget that part. And once you have, if they are asking you what are the investigations you are going to do, then start from the routine investigations. If they are asking you which investigation will pinpoint your diagnosis, then you give the answers like this that you are giving. So there are two ways of asking the question. Which investigations you want to do? Then you say, I'll go for routine blood investigations. I'll go for the anti-GM1 positivity in the anti-ganglioside antibodies. I'll go for the infection screens. I'll go for the stool culture, CSF, NCB, MRI. Go on telling all these things. They can ask you about the differential diagnosis. So you might not be remembering that time suddenly. But start thinking, take one thing at a time. Like now, if you would have been in the nerve route, what would have happened? So the muscle problems, maybe hypokalemic periodic paralysis. At least one or two definitely will come into your mind. 2, 3, 4 will come into your mind. I think if you say 3 or 4, that will be enough. They might be asking you this question. And then they may go into a question where they may ask you, how do you treat? Now, there they might be giving you a bit difficult scenarios. So if you are going to treat, whether you use IVIG or you use plasma exchange. So IVIG, you all know about the dose. That is very easy. That you know now. They will basically not stick on IVIG. They'll come to the plasma exchange. Now, suppose they may ask you one question, very tricky one. Suppose the patient is on IVIG. You have given the IVIG. And the patient is not responding. Should you go for plasma treatment, the plasma, or that is plasma exchange, or you not go for plasma exchange? Yes or no?
Repeat IVIG. Should
Yes.
wait, sir.
So there is no role of plasmapheresis after IVIG, but there are few studies which have supported this, but there are no standard recommendation guidelines for doing plasmapheresis after a failed course of IVIG.
All right. So according to you, I'll not go for plasma exchange. Your answer is no, isn't it? You are telling no, basically.
Yes.
Yes, sir. Combination.
All right. Anyone else? There are no studies. I know that there is no randomized control trial on this. But if the patient is failing on your IVIGs, there is no contraindication of plasma exchange. There is no contraindication also. But you have to wait for some time before you start, because you have to read this IVIG Act. Otherwise, you will also be removing the whole thing from unless otherwise it's settled into the nerve roots. So maybe they are also the people are not sure whether you have to start it after 7 days or 10 days. Somebody has started even as early as 4 days, and they have found potential benefits. So if they go to the modalities, they may ask you, what are the treatment modalities? If you are going for plasma exchange, what are the types of plasma exchange? They may ask you. So you read plasma exchange well, all right, because inside the ICU, which type of plasma exchange do you do? Because your patient of Gulenberry, I'm coming to the last and the most important part of that, which your patient, suppose your patient is intubated. So will you, many of times your plasma exchange machines, which are used by the blood bank, they're inside the blood bank. They do not carry to the ICU. So what are the different types of plasma exchange? Do you know? So one is a
centrifuge.
Exactly, centrifuge that is being used by normally in the blood banks, which is more effective actually. Whereas because it extracts plasma around 80% in one go. Whereas the easier one that we do is with the help of a membrane that is acting on the by the process of convection, and there the plasma exchange we take around only 30% is being extracted. So at least 3 to 4 plasma exchanges has to be done, and uh, this is a slower process. But the point what I'm asking you is that uh, there are different side effects, and they'll not ask you this type of question. The important point of a Gulenberry is about the respiratory function, because they'll be asking you when exactly you'll be understanding whether your patients need some amount of assisted ventilation. So there are different type of parameters that can be used. So you might have to use a spirometry by the bedside, and you can find that exactly what is the status of the patient, and you might have to intubate the patient in these type of situations. So Gulenberry is a very important question, especially do not forget it's Bickerstaff variety is a very rare one. Yes, brainstem encephalitis is the last one, the Miller-Fisher syndrome, and this type of patients might be presenting to you, and they might be giving a history of this last two, rather than this ones, and might be confusing you because they consider you to be a consultant. So this type of questions, that is, and what we are discussing about, we left this one in the middle about this peripartum or the postpartum peripartum cardiomyopathy. That means they are basically wanting you that you should be knowing the definition very well. These two very important points, ejection fraction less than 45%, and the fractional shortening less than 30%, and the end diastolic dimension more than 2.7 centimeter. I mean, this is very important. So this part they are giving it here. Ejection fraction 37%, fractional 17.4%. This is basically the diagnostic law. That's what they want to say. This is one of the pictures from my own patient. So I gave it here. So they may ask you what are the risk factors. So these are the theoretical questions they might be coming after that. Remember, the prognosis they might be asking you when you are going to do this is so important. If endomyocardial biopsy, if they should be considered if there is no improvement after 2 weeks of heart failure therapy. So they might be asking you as a corollary, the last question maybe. So when you are going to have a biopsy. So these questions will be coming. So see here, this is a question again, very easy for you. Because the hints will be there. Because you don't have much of time. 3 questions will be there, around 20 minutes each you will be getting. So you will not have much of time. So one hint will give you the answer. What is the hint here in the third line? You don't have to read anything else. That hint will show you.
Knee replacement.
Knee replacement. After that, there is breathlessness. So what has happened?
Pulmonary embolism. D-dimer high.
Yes, exactly. So now, but see, exactly, the D-dimer is raised, the BNP is raised, the troponin is not so raised. But if the troponin would have been raised, the situation would have been worse. The prognosis is very bad. So you have to go for immediate hospitalization and thrombolysis. So why they are giving you these figures, TAPSE, MAPSE, PSP divided by LVSV. So you have to read these things which are coming in the pulmonary embolism in the echocardiography. And the point is that in pulmonary embolism, again, I'm going to stress, every time I stress, you also know about it. If the patient is on ventilator and the patient suddenly starts desaturating, the hemodynamics going down, but the peak pressure and the plateau pressure are absolutely normal. So that is the situation. This is basically indicating the patient is having some pulmonary problem. So this part, they are giving you, why they are giving these points? They are giving you basically so that you can understand it. They want you to answer and they want you to pass. And that is the reason they'll give you so many things and they'll be giving you these figures so that they'll be coming in the question. And they'll be asking you, as I told you, what are the, how do you basically, you should be knowing this one. At least one version you keep in your mind. See, if you see here, they'll give you a 66-year-old car mechanic. 65 years, more than 65 years, 1 point. Every point is important. And see what they've given, heart rate. Again, heart rate they might have been given here. Blood pressure 70/40, pulse rate 120 per minute. So obviously, again you are scoring either 2 and 1, 3. These 3 points has already come here. In this way, you have to keep this in your mind because certain scores you have to be remembering. And one of them is this one. In pulmonary embolism, the score has to be remembered during the exam. At least one score. The simplified PACE score or the PACE score is very bigger one, the simplified PACE score. You have to remember this. And I got this one in my exam, this ECG, the right one. I was completely confused. I couldn't understand what is the ECG. They directly gave me this ECG. It suddenly struck my mind it is S1QT33. Unfortunately, it is found only in 20 to 30% of the patients, but still it is, I don't know, it is very popular worldwide. S1Q3T3 syndrome. So here you have a veins, which are, you have a DVT here, you have a D-shaped in the short parasternal view, and the D-dimer is raised. What is the cutoff level of D-dimer? Age adjusted cutoff is age into 10. Suppose 50 years, so it's 50 into 10. So there is minimum is 500. So above that. So troponin I increase, that means it is an independent risk factor for short-term mortality. So these things are very important. This is the whole echocardiographic finding that we can find in a pulmonary embolism. There is something called the 60-60 sign. We don't normally see it, but they might be asking you, tricuspid annular systolic velocity is less than 9. These things we see. Normally we try to see all these things. So remember these things, my dear friends. So I'm sure that it will not be forgetting all these things and will be answering very well. So, and this is the standard one they'll be giving you. Standard question. And they'll be going anywhere from here. One question that you will get like this. You take it from me. Because this is the bread and butter of intensive care. So you have everything here. Have you seen? You have everything here. So they can, from here, this is a case of sepsis going into ARDS, a pneumonitis, community acquired pneumonia, which comes going into, maybe into ARDS, they have not given on the signs, because by the definition, you will not exactly can say this is ARDS. You have to say the patient is in what type of hypoxia, and from there, the patient is having, see, hyperkalemia, the patient is going into AKI. So now they will enter into the broad scenario of sepsis. They'll start with fluid resuscitation. They'll go into the crystalloid or colloids, why crystalloids, which crystalloid. They'll go into the resuscitation dynamics, then hemodynamics. So in this case, how many of you will be doing the pulse pressure variation, stroke volume variation, and plethysmographic variability index? Yes. All this one. Pulse pressure and stroke volume, how many of you will be doing? This is a patient where the patient is going into
we cannot do pulse pressure variation in ARDS patients because tidal volume will be low and patients will be mechanically ventilated in controlled ventilation. These measures are valid for spontaneously breathing patients.
Priyanka, are you sure that the pulse pressure variation is seen in spontaneously breathing patients, or you need a completely paralyzed patient?
For mechanically ventilated patient with high volume and controlled patient.
We have to be,
Passive leg raise.
so one part of it is right that for a low tidal volume, I cannot use pulse pressure variation. But the patient has to be completely paralyzed to see pulse pressure variation, isn't it?
Yes.
The patient has to be paralyzed. The patient has to be have a tidal volume of 6 ml per kg body weight. The patient should not have any arrhythmias. The patient should not have any cardiac dysfunction. So how many patients will be getting like this to see the pulse pressure variation? So they must be asking you which of the hemodynamic parameters, that is dynamic parameters, you find appropriate in this case. This will be the question. They'll not ask you a broad question that what are the dynamic parameters that you see?
Passive leg
And
raise.
if ask also, you don't utter this pulse pressure and stroke volume variation here.
So change in cardiac output by more than 10 to 15% after passive leg raising will be best in this.
Yes. So, or you can go for a tidal volume challenge test also. That also you can go. You can see the change in the cardiac output. You can change in the VTI that you can see. If you don't have that thing, you can change in the ETCO2 also will help you. Or in this case, an end expiratory occlusion and the change in the cardiac output might be helping you. And again, they must be asking, they might not be asking you because they don't have much of scope to ask these questions. Well, because after this question, the question comes, how do you see the cardiac output with which monitor?
Echo. Esophageal Doppler.
So again with the echo, again the question will come, how do you see your cardiac output in the echo?
VTI, we measure VTI and we assess stroke volume with the help of VTI. We also measure the LVOT diameter and then we calculate the volume of the LVOT, which is we consider like a cylinder, and the volume of that cylinder will give us the cardiac output.
So I find the LVOT diameter in the parasternal long axis view, and I find the VTI in the apical view, isn't it? These two views are different. So I have to take the LVOT diameter in the parasternal long axis. I have to take the VTI in the apical view, and then I have to calculate it myself. There are certain nowadays good ultrasounds and echo machines specifically designed for the critical care is coming where they measure it themselves. So they can ask you another question. If the patient is in a resource limited situation, because they know many of your examinees, they'll be coming from a resource constrained situation, resource limited. What should be your dynamic parameter that you can use?
Capillary refill time.
Yes, we can see the capillary refill time, fine. Andromeda shock trial. But
passive leg raising.
Plethysmographic variability index, PVI.
And the inferior vena compressibility. That's also very important.
Yes, we can go for the inferior vena cover with the help of ultrasound. But what about the last line that I have written here?
In echo.
There is also a mottling score.
Yes, mottling, fine. Yes, we can see the mottling, but how much of us, because see, mottling is a good thing that you have to speak out because you are giving the exam in Europe. People are fair-skinned there, you can see the mottling. But in a black-skinned people, is it possible to understand the mottling? Very difficult. What about the last line?
Pulse pressure.
Only the pulse pressure. Now, why I have written this? Why I have given this to you? This is because if you have still not read the surviving sepsis compel from head to toe, go and read it today. Take your whole time of 2 hours and read the whole thing, including whatever they have written inside. There you will find it. They have written this one. But they have not given it into their own recommendations. So, rise in pulse pressure more than 15% after a PLR of 60 to 90 seconds is an indicator of fluid responsiveness. Now, they will again ask you the moment you go for fluid responsiveness, because this is the new terminologies that are coming, what is the difference between responsiveness and tolerance? So, they might be asking you this question because this is the new things that are coming up. For example, if they go to AKI, they will be asking you about the phenotypes and the subphenotypes because there are new things that has come up in 24 and onwards. They might be asking you the ABCs and the ABG, the comparison between the arterial blood gas and the situation that is done in the in your AKI. Go by the Ronco paper 2020, you will find he has given a very good comparison between the how do you compare between an ABG and ABC. Might be somewhere they must be asking you. We don't know. But obviously, simple things like gradients, they have also told about these things in the surviving sepsis campaign. So these things are written in the corollary. They are not being shown in the main documentation and the main your uh, recommendations. Similarly, in fluid, they will ask you anything about fluid. Where from this 30 ml per kg came? They might not be asking you, but we should be knowing this figure, where from did it come? This absolutely a bizarre figure of no clinical significance. But they have given this a weak recommendation, low quality of evidence. And ultimately, they are saying individualize. The very easy terminology to always tell why they are coming from the 3 trials, process, promise, and arise. They found that they've used this amount of fluid there, average. So they have given this recommendation. And we also know this is much a thing which cannot be believed all the time. So that was what we are discussing actually. So can you hear me now?
Yes.
Can you hear me? All
Yes.
right, all right. So you all know about the crystalloids. They must be asking you. They will not give you a chance to discuss about the different type of studies that has come. They'll not ask you, but definitely they'll ask you about the dynamic parameters. Take it for granted. Everybody will be asked this question, and once they goes into, they'll be loving to go into the vasopressors, and you should be knowing everything about the vasopressors. When the norepinephrine, what is the dose? When should you go to when should you go to your vasopressin? What is the dose? When should you go to non-adrenaline? And can anybody tell me how do you basically take off these vasopressors? Take out? How do you stop? Because normally we do not discuss that. How do you stop the vasopressors? They'll ask you. And can you tell me any trial that has been done on that? And definitely they'll ask you when you start inotrop. If you don't have an echocardiograph, how do you basically decide on when to start dobutamine?
Difference in arterial venous PCO2 more than 6 to 8 millimeters mercury and SCBO2 less than 70%. Then we decide on to start the inotropic agent, either dobutamine or milrinone.
Moment you tell milrinone, I don't know whether they'll be happy to hear that or not. Because again, that is not there in the guideline. So as it is not in the guideline, better to say I'll use the dobutamine. If there is any chance that what are the inotropes, then you say milrinone. See the question properly. Which when do you start an ionotrop? An ionotrop. That means they're asking you one ionotrop. When you start the ionotrops, they will ask 2, 3, whatever you like. And if you are telling, then stay yes, levosimendan is a no. It has no advantage over it. If you get a chance, they'll not ask you. I can tell you that. But they can ask you on this one, that is, how do you withdraw? And when do you, is there any role of dopamine that we already discussed? Everybody knows nowadays. Dopamine. Dopamine?
Sir, in SOAP2 trial, dopamine was shown to have higher incidence of adverse effects. Ventricular tachycardia and arrhythmias were higher. So dopamine
what is the current role of dopamine in clinical practice, in normal intensive care practice? Is it used or not used?
It is prescribed only in cases of shock with signs of low cardiac output with bradycardia, symptomatic
Fantastic. All
bradycardia.
right. Well, so the answer is correct. Fantastic. So this they will ask you this one. They will go into the AKI and they'll ask you name one biomarker that will be using nowadays in AKI. If they ask you like this, one biomarker. Name one biomarker which will be used in AKI. If they ask this question like
Cystatin
this.
C.
Yes? Cystatin
Nephrocheck.
C, you are telling? Anybody else? Because they will be not be asking you cystatin C. That is the reason they are not
IGF
giving this one.
BP7,
NGAN.
BP7, NF.
NGAN can be used.
And yes, IBF BP7 and NGAL, they will not be asking about NGAL. These are being used for the last 10, 15 years, which is the latest one that has been used. Yes, IBF BP7 and
kidney injury molecule.
which one?
Kidney injury molecule, sir.
Kim again has been used for the last 10 years.
TIMP2 IGFBP7, which is called nephrocheck. We measure urinary levels of nephrocheck for as a marker of AKI.
TIMP2 plus IFBP7. We measured these two, isn't it?
Yes.
We measured the TIMP2, that is tissue inhibitory metalloprotein 2, plus IFBP7, that is insulin growth factor 7, in the urine. This you want to mean?
Yes, sir.
No, it is multiplied factor. TIMP2 multiplied by IGFBP7. If this value comes to be 0.3, that means more than 0.3, then that is the point that you will tell that this patient is going towards severe AKI. Now they have divided it to 0.3, 0.3 to 2, more than 2. In this way, they have come into a classification also. It's the multiplication factor of TIMP2 and IGFBP7. The whole factor is known as the nephrocheck in the market. You are right. It is seen in the urine, but it is, again, it is a stress marker. That is when the kidneys are basically, nothing has happened to the kidneys, only the stress has happened. That means the creatinine will be all right, urine output will be all right, everything is fine, but this will be raised. And it has been mainly validated in cardiac surgery patients. And also, they have given this classification that I'm telling. Apart from that, it is not so reliable in certain situations. What are those situations? So in a patient who is having a CKD with lot of proteinuria, this is not significant. This is not at all to be used. And also in patients who are having high bilirubin levels, TIP2 IGFBP7 multiplication factor is not found to be effective. So you should be knowing about this nephrocheck, everything. Go and read this one. They'll be asking you this. Many a times I may be also wrong. If I'm wrong, correct it myself. You have all my numbers. So it is not possible for me also to know everything. So they can be asked you by the bedside what you want to see. So you know all that, how to see the bedside. You should not miss this one, fusidic stress test. Should not miss the renal angina index. These two you should not miss in AKI. Should not miss. Now, when it comes to CRRT, naturally, what are the causes where it is to be used that they will not ask you, but when to start again, these trials have come up. You have no scope that they will ask you about a trial, but this is the Bagshaw that gave in 2013. This is a very practical one of how to utilize CRRT. We have modified a bit in our own situations and using this one. The dose of CRRT, they might be asking you 20 to 25 ml per kg per hour of effluent volume, but you have to prescribe more because you have a lot of downtimes. They must be asking you which is the best anticoagulant. Citrate is now used, regional citrate, but regional citrate, when it should not be used, they should be asking you this question. When regional citrate should not be used in CRRT?
Liver failure, hypocalcemia.
Liver failure and severe hypocalcemia.
Again, they have seen that in liver failure patients also, citrate sometimes is, they have not always that it is bad. So you have to basically, they will ask you what is the difference between the citrate load and the citrate toxicity. So go and read this one today. Not all the times it's not possible to again discuss all this. Go and read the difference between load and toxicity when metabolic acidosis starts occurring when I'm using citrate. That is the time I stop citrate, because citrate is not going to get converted to bicarbonate. But remember, one of the very big important cutoff level of citrate is the lactate level. When the lactate level in one of the studies, they have even quoted down as much as 3.4. But around lactate level of 6 and above, in some studies 8 and above. So if you say the higher lactate level patients, so the patient is already very severely septic, higher lactate level patients, citrate has to be used with caution. So this, you remember this one, liver toxicity, definitely. Citrate, you read everything. Go and read citrate from a good book today, because they will be asking you citrate. Because citrate is the latest one, they're using it. Everybody is using it, so they're very excited about it. In CRRT, they'll ask you the citrate, they'll ask you the dose, they'll ask you about the slow continuous ultrafiltration. They can ask you some off-level use of CRRT. Can anybody tell?
Encephalopathy.
Yes. So if they ask you the patient is in hyperammonemia, what is the you use CRRT, which mode and what dose?
High flow hemofiltration.
Right. So see, we don't use 20 to 25 milligram per ml per kg per hour here. We are using up to 50 ml per kg per hour. So they'll be asking, what is, if you are using so much of high flow hemofiltration, what is the problem that can happen to the patient? And why it is being used such a high flow in hyperammonemia? Because ammonia has... Yes, but there is a phenomenon called rebound phenomenon. Basically, it comes back again from the tissues in the blood. So once it is removed, some of them are basically going and basically hiding them in the tissues again. When the process stops, it comes back. So the ammonia level again goes up. So that is the reason you have to go for a very high flow to remove the whole of ammonia. This is number one. And number two, high flow hemofiltration with such amount of huge ultrafiltration, hypotension may be one of the causes. Moment you turn into hypotension, they'll ask you what are the causes. If there might be a question, they might be in the flow, then we ask you how to prevent hypotension in a case of RRT. Remember, if you are telling RRT, it is not CRRT. It may be SLED, it may be hemodialysis, intermittent hemodialysis. So RRT, there it is, their intradialytic hypotension, IDH. And for CRRT, it is HIRRT, hemodynamic event incidents in renal replacement therapy. These two terminologies run side by side, but quite different, because HIRRT is an acute phenomenon in an acute patient, whereas intradialytic hypotension is mainly found in patients who are chronically ill coming for intermittent hemodialysis. So these two differences you have to know. You have to decrease the temperature of the fluids. All right, so what we do, we give calcium. How do we check it out? Intradialytic hypotension, we decrease on the ultrafiltration rate. That is the main problem. We should not beyond. This is for intermittent hemodialysis and SLED, I'm telling. I should not go beyond the ultrafiltration of less 13 ml per kg per hour. And whereas in CRRT, the main hypotension occurs due to the patient fluid removal. That is the fluid that I am not replacing back to the patient. That is the only scuff. If I do a very high dose of scuff, it will cause hemodynamic instability. So I do not cross a value of 1.75 ml per kg per hour of scuff. So that means around 150 ml per hour. I should not exceed that. So again, my dear friends, CRRT is a vast ocean, very difficult to discuss, but it is one of my favorite subjects, so I can't stop myself when I talk about it. So go and read it very well. You can find many of our lectures in the YouTube. If you need the dose and the prescription, you can go there. So best of luck to all of you. I am talking for the last 1.5 hours. So I am sure that all of you will come out in flying colors in this exam, because I have seen you, many of you are answering very well. Remember, read the question well. Read the question well. Hint will be there in the question. every inch of the every line, every word of the question is very important. And read that I'm telling you, which inotrop you want to use, which inotrops you want to use. See the plurality and the singularity of the question. The Minoka, as I've told you, what is the broad diagnosis they're asking? They're not asking you about Takotsubo. They're telling which condition do you think is associated with this broad diagnosis, then Takotsubo. So read the question well, because they frame the questions like that. And again, best of luck. I know there are so many questions might be there in your mind. Again, difficult to answer all the questions, but if you have any questions, you can write it down to me uh, in my email, and we'll be happy to answer those. But I don't think that in 2 or 3 days anything will change, and most of you and all of you will pass. Thank you so much.